All right, very good day, everyone. First of all, on behalf of me, myself, and also the team from Indonesia, let's give a round of big applause to Dr. Hari Krishnan, Yashoda Hospital, and Bronchus 2025 for this great event. Let's give them a round of applause. Yes, excellent. All right, so my name is Eric. This is my third time in Bronchus. So I learned a lot actually pretty from your slides. So that's why I think it's very, very important for us to actually understand the basics, how we should do EBUS TBNA, and whether we should perform cryobiopsy on every mediastinal lymphadenopathy in patients with lung cancer. So let's start. So as the introduction, since the emergence of EBUS TBNA by Professor Yasufuku and so many professors who actually attend events, we learned that we actually can maximize the results of the biopsy itself by doing simply a minimally invasive procedure. Even we can do this procedure to our outpatients. It can also give us a real-time image of the ultrasound, which is provided by the scope itself. And again, this is a very standard, basic lung cancer staging procedure. And there, since ERBI launched their new cryoprobe, which is the 1.1 cryoprobe, so now we understand there's a new terminology which actually, I think, if I'm not mistaken, it was first introduced by our dear friend here, Dr. Hari Krishnan. It's transbronchial cryo-nodal biopsy. So what is TBCNB? So TBCNB is an advanced technique that actually use cryobiopsy probe instead of use your conventional needle aspirations while doing EBUS. Again, so what's the advantage of this cryobiopsy instead of using the conventional or traditional EBUS needle? First, it will give you a much larger tissue samples. And I'm very, very sure that we can agree that size is matter when it comes to histopathological assessment. So again, it will improve your diagnostic yield, especially for benign condition and tumors that require a subtyping. So before this discussion, before this presentation, I get a lot of questions. So Eric, when should we actually consider to do TBCNB? In what situation? So based on a lot of publications about TBCNB, so yes, we can actually consider to use this for benign condition. Again, in the context of lung cancer, it will increase the diagnostic yield, especially when we want to run a molecular testing like EGFR, PD-L1, ALK, so on and so forth. Again, it will increase the possibility of our patients to get targeted therapy, especially in patients with non-small cell lung carcinoma. So this is quite very, very clear for every one of us to read, so I don't need to read one by one on every point. But again, the EBUS TBCNB is actually can perform, we can use our flexible bronchoscope. We still need the EBUS scope to guide us. But again, we need to remove the specimen and block. The optimal freezing time, as I discussed with Sammy and one of our friends, Dr. Ko, he published a paper about the freezing time. And it's around 4 seconds. And before this, actually, the cryo was widely used to diagnose IPF or DPLD. So other indications of the cryobiopsy, we use this quite a lot for peripheral pulmonary lesions, right? Under fluoroscopy guidance or con-beam CT. So this is the pictures of EBUS TBNA. Now they will come with slim EBUS. And then this is the image that you will get from the ultrasound. And then, as I mentioned before, we use 1.1 cryoprobe to actually do TBCNB. So I'm sure everyone are familiar enough with this procedure. So this is one of the procedure, and this is when I'm still very, very young, probably 10 years ago. So this is the conventional EBUS TBNA, right? So you pass the needle after you locate using your ultrasound, and then you do the jabbing with slow pull method. Again, with slow pull method, you wish to increase or you wish to get more specimens in terms of volumes, of course, and also the size of the specimen. Again, the aim is to get this specimen adequate enough to run for immunohistochemistry and molecular testing, as what suggested by European Society of Medical Oncology. So how we perform EBUS TB-CNB? So again, we use EBUS scope still. We still need to locate the enlargement of mediastinal lymphadenopathy. And then after that, we can use the 1.1 mm cryoprobe. But in many centers, also in my centers, we use 21 gauge needle. Some other centers use 19 gauge needle, which is slightly bigger. But again, so after you pass the 21 gauge needle or 19 gauge needle, and then you smoothly use the needle track and introduce your 1.1 cryoprobe to the lymph node, right? And then you will get this very beautiful specimen just within 3 or 4 second freezing activations. So again, the gold standard from meta-analysis, so we have 14 studies. The results is the diagnostic yield actually for EBUS TBNA is actually very, very good. So it falls between 84 to 92%, and the sensitivity is actually 91%. While the complications rate for EBUS TBNA is actually very, very low, and majority of the complications actually very minor. I never experienced any major complications doing EBUS for the past 15 years. So although from this publication back in 2020, the authors didn't conclude if EBUS actually safe and accurate, but again, EBUS procedure is very operator dependent. It's up to the operator, the man behind the gun, right? So again, we need more high quality studies and more prospective studies. But so if we compare with chest CT or PET scan, I think one of the caveats is we still need to understand, especially in India, Indonesia, in my country, we're still battling with tuberculosis. So one of the caveats is if you saw or if you witness any enlargements of the lymph node, do not ever take into your consideration that you don't need to sample that station. No, you shouldn't. You still need to sample the lymph nodes, right? So again, EBUS TBNA has a better sensitivity and specificity, also diagnostic accuracy. The negative predictive value is actually about 91%. As suggested by ACCP, that select EBUS TBNA is the best initial test, especially in patients with N2 or N3 diseases, which is contralateral, right? So again, yes, it's good to have PET CT, but to sample the mediastinal lymphadenopathy is actually very, very important. So result clinically suspicious nodes should be followed with surgical sampling if the result was not very good. So this is just quite a reminder for us about the role of rapid on-site cytology examination of ROSE. As suggested by chest in patients with suspected malignant disease undergoing EBUS TBNA, we suggest, or chest actually suggests, to utilize rapid on-site evaluation over usual care. Again, this is a conditional recommendations with very low certainty of evidence because it's up to the pathologist to read. It's very subjective. Again, using ROSE, it will not increase the diagnostic yield of the EBUS. I mentioned before, it's up to the man behind the gun. Second, from the meta-analysis, we also understand there's no significant difference in terms of diagnostic yield, procedure time, or how many passes that you need to sample the lymph nodes. It will, or it might reduce your number of aspirations, but again, back to the ACCP recommendations, ROSE is actually not mandatory. I'm quite privileged to have ROSE on my center, but again, I still need about 3, at minimum 3, but the suggested actually 4 needle passes on every enlarged lymph node. So this is a very nice and beautifully written paper from Hari. So Harry published this at Respirology Case Reports back in 2021. So this is a novel approach of transbronchial cryonode biopsy. So as compared to the EBUS TBNA, this is actually, we don't need any additional incisions. Again, you can just use the needle track that you created using the EBUS TBNA 19-gauge needle or 21-gauge needle, and you can get larger specimen, you get better quality in terms of biopsy specimen, real-time ultrasound, and very minimal complications. So this is just an overview of other studies that actually talk about EBUS TBNA and EBUS TBCNB. The last publication is actually from our very own friends from Malaysia, Ian Su. So Ian published a paper less than a year ago about EBUS TBCNB. So EBUS TBCNB found was quite superior in terms of diagnosing rare malignancies and also benign conditions that actually probably missed while we sampling using the conventional EBUS TBNA. Right, how about NGS? I mentioned earlier that one of the aim of us doing EBUS TBNA, we want to get more adequate sample in terms of molecular testing so that the next genome sequencing for the patient specimen can be done. So if you look at the table here, the tumor cell area and tumor content, the p-value is very significant. So there's a significant difference between samples using TBCNB technique as compared to TBNA, right? So what does it mean? So higher tumor cells concentration means more reliable for genetic analysis. Again, EBUS TBNA sample, sometimes we get more blood contamination. I will show you in the next few slides. And then most of the sample are crushed. But again, do we need that? Take into our consideration? I will show you after this. So again, we can still use the 21-gauge needle, which I'm sure everyone have 21-gauge needle here. In Indonesia, we don't have the 19-gauge needle yet. But if you want to compare the optimal needle sizes, on the left is actually the conventional needle size, which is 21 and 22-gauge needle. And on the right one is a 19-gauge needle. So again, there's no significant difference in terms of diagnostic yield, specimen adequacy. But again, if you use the 21-gauge needle, yes, we need fewer passes using 21-gauge needle as compared to 22-gauge needle. And also for benign disease, because larger needle, then we can get better specimen, especially for benign. So 21 is much more superior as compared to 22-gauge needle. And also for 19-gauge needle, there's only one study that showed improved diagnostic yield in 19-gauge needle, while another study actually showed no difference. And I just want to move on with my own research. So this is my research together with Konstantina Kontogiani back when we were still doing our PhD. So this is, if I'm not mistaken, one of the largest EBUS TBNA research, especially on the size of the needle, which we compare the 19-gauge needle and 21-gauge needle. So if you can see here, we actually use both 19-gauge needle, sample on the same station, and do the histopathology examination. There's no significant difference in terms of Mayer score, diagnostic yield, or even complications rate. But again, to use 19-gauge needle, especially for patients with lymphoma, it will give you much more cells. The cells is much more complete, and it's not crusted as compared to the 21-gauge needle. So again, the conclusion from our study shows that the flex 19-gauge EBUS TBNA needle was actually safely used in this study. There's no significant difference in terms of diagnostic yields, but the efficacy is actually quite similar, as I mentioned earlier. Again, talking about the needle passes and freezing time for transbronchial needle cryobiopsy. So optimal specimen size, we can reach about 4 to 6 millimeters. We need about 4 passes, 2 to 3, about 85%. 4 passes did not significantly improve. So if you want to do more than 3, it will not significantly improve be diagnostic yield while you perform TBC and LB. And then the freezing time is about 4 seconds. So again, this is a very beautiful image from Dr. Ko. So how about the safety profile? There's no significant difference if we want to compare with EBUS TBNA, to be honest. Again, from this publication back in 2017, EBUS TBNA is actually quite safe procedure and is widely used everywhere to diagnose patients with lung cancer. How about the TBCNB and TBNA? Complications rate, there's no significant difference, probably a bit more higher in terms of the bleeding risk if we use the cryo as compared to TBNA. But again, it's very much controlled. And then about the bleeding for the safety profile for the TBCNB is about 4.9%. And also for the pneumothoraces, again, the rate after TBCNB is about 9.5%, and it's still manageable, it's still acceptable. So I think I almost reached to the end of my presentation. So this is the summary of the 2 hours of my talk, right? So I summarized to this table, right? So if you want to have a snapshot, go ahead. So let's move. Okay, so let's move on. So again, I'm just going to leave you with no conclusion, but I'm going to give you a statement saying that, well, I guess when you can aspirate the truth. So EBUS TBNA takes the mystery out of lung cancer staging, definitely yes, giving us a real-time, high-definition insights with minimal invasion. Your precision, efficiency is important, your needle's touch, because lung cancer diagnosis deserve nothing less. Thank you very much.